really well and in really good detail for you guys. And I'm sure she's mentioned meds and gone over that before, but just go ahead and go review your cardiac complex health 1 exam review. Especially you're going to want to review those signs and symptoms of each disease and disorder, because that's going to help you with your medications. If you know you're giving this to treat the symptoms of hypertension, you know what to look out for if you give too much or too little, things like that. So first, we're going to start with our adrenergic agonists and our adrenergic blockers. So first, we have our clonidine. This is a centrally acting alpha agonist. This medication is generally used for our patients who have super hard to control hypertension or high blood pressure. So it's going to kind of decrease that constriction of the blood vessels, that we know cause that hypertension. We're going to want it to lower our blood pressure. So the main action of this medication is to lower our blood pressure in our patients with hard to control hypertension. Our side effects are pretty similar to beta blockers, which we're going to go over next, but they do occur more often because this is a stronger medication. Sorry, I lost it. There we go. So basically, we just have our patients with sodium and water retention. So as nurses, we kind of need to teach our patients to monitor and look out for water retention or edema. So we kind of look at our legs, see if they have any swelling in their legs or their hands, any peripheral edema. And then, our dry mouth, all those symptoms like that. And then if we do have a lot of water retention, we're going to give them diuretics, which we're going to go over towards the end of the review. But basically, this medication is just used for our very hard to control hypertension. And another really important thing for all of our medications used for hypertension, we never ever want to have our patients abruptly stop them. So kind of like steroids, we kind of want to taper off of our antihypertensives because it can cause rebound hypertension, which is just basically, they're slowly going down and they have controlled blood pressure, and then they stop taking it one day and then their blood pressure skyrockets. Next are our beta blockers, which are very common medications. You guys are going to see these a lot on ATI, NCLEX, in-class exams, in the clinical setting too. So these are beta adrenergic blockers or beta blockers. These are LOL drugs, so they all end in LOL. These are going to slow down the beat of the heart. So atenolol and metoprolol are selective. So these are only going to affect the heart rate. They're not going to cause that vasodilation. So they're not really going to work for our hypertension because they only are selective to our heart. And then propranolol is non-selective. So that is going to work with the heart, the lungs, and the arteries. So very important to know our propranolol. We don't want to kind of give that to our asthmatics or our COPD patients because it can affect the lungs and cause exacerbations of those two disorders. So basically, it just decreases that heart rate and the force that the heart is contracting to lower that workload of the heart. So we see it a lot in our patients with heart failure. And it also works to lower blood pressure, but that's going to be our non-selective ones. Main side effects are dizziness is a main one. A lot of our patients are going to have those, hypotensive side effects because we're giving it to lower that heart rate and that blood pressure. So dizziness, lightheadedness, orthostatic hypotension. So we want to make sure that we're monitoring our vital signs, especially our heart rate. So when we give this medication, we want to always check our patients' apical pulse and their blood pressure. So does anyone know the heart rate that we would hold this medication for? What below that would we not give it? Yep, 60. So if we assess our patient's pulse and they have a heart rate below 60, we are going to hold this medication because we know it affects the heart rate specifically. So next we have our anticholinergics. I just have one of these, our atropine. So basically our atropine is going to block that action of the vagus nerve. So we know that our vagus nerve is responsible for our rest and digest. So when our patients have really slow heart rate or bradycardia, we're going to give them atropine to kind of bring their heart rate back up, higher than 60. So our bradycardic patients they're going to be given atropine. And again, atropine is used sometimes for our pre-op patients who have maybe too many secretions. Same with like some of our intubated patients, they just have too many secretions and they're getting suctioned too often. So we can give them atropine to kind of dry everything out. So our side effects are much like our Benadryl. So it's going to be that blurred vision, dry mouth, urinary retention or hesitancy, and then it can cause tachycardia because we're giving it to increase that heart rate. So if we're giving too much, we have too high of a heart rate. But basically, atropine is mainly used, and you're mainly going to see this on ATI, that it's used to speed up the heart rate. So for our nursing care, we just want to educate our patients, if they're having any of those dry symptoms, the 4 dries that we always talk about, hard candies, sugar-free candies, increase their fluid intake, ice chips, things like that. Okay, next we have our anti-inflammatories. So I just want to go over kind of the difference between our COX-1 and our COX-2. So our COX-1 is going to be our beneficial kind of enzyme that is, good for our GI. So we know a lot of our anti-inflammatories, especially our NSAIDs, are not really good for our tummies. They kind of inflame it and they can cause bleeding. So our COX-1 is beneficial because it's going to protect our stomachs. And then our COX-2 is harmful. So that's the things that are going to cause like pain and fever and things like that. So COX-1 is good, COX-2 is harmful. So when we're looking at actions, this will kind of help us figure out what this medication is doing if we know which COX inhibitor it's going to affect. So we have our aspirin. Our aspirin is used for kind of 2 different things. So we have our patients on aspirin because they need to reduce that platelet aggregation, which is the stickiness of the platelets. And then we have our patients on aspirin because it is an analgesic, it reduces pain. So this is going to be a first-gen NSAID. It stops COX-1 and COX-2. So we know that COX-1 is good. So if it's stopping that, we know that this is going to have some GI side effects. Because yes, it's stopping the pain and the fever, and it's stopping that platelet aggregation, so it's making our blood thinner, but it's also stopping the COX-1, which is protecting our tummies. So if we have patients who, are losing all that COX-1, they're going to have those GI symptoms. And then another really important thing with this is if it is given in too high of doses or they're nearing toxicity, they can have tinnitus, which is ringing in the ears. So that's just kind of due to excessive aspirin intake. And then for our pediatric patients, we never ever want to give them aspirin. So if you see that on a question, know that you should never give pediatric patients aspirin because it can cause Ray's syndrome. And then the therapeutic level, I don't know if you guys need to know this, but the therapeutic level for aspirin before it's toxic is 15 to 35 milligrams. But that's a little complex. But for our patients who are taking it to suppress that platelet aggregation to make their blood thinner, we want to make sure that we're getting good medication history, because if they're taking this with other anticoagulants or blood thinners, it's going to increase that risk for bleeding or hemorrhage. And then also if they're having any upper GI bleeds and things like that. So next we have our ibuprofen, our Motrin Advil. I'm sure you guys are very familiar with this one. This is a first generation NSAID. So this is used for pain, fever, anti-inflammatory. Again, this inhibits COX-1 and COX-2. So we're going to have some pretty bad GI side effects, and that's why you never want to take ibuprofen without a snack or like a cracker or something, because it can cause some GI upset. But pretty much the same as like aspirin side effect wise. It's not really used though for platelet aggregation, mostly just used for pain and fevers. But again, we know that this one affects our COX-1 inhibitor, so we're going to want to monitor for any GI upset. So always encourage our patients to take this with food. Okay, so next we have our celecoxib. This is another NSAID, but this is a second gen. So it's going to have those, as we go down the generations, we know that less generations, they have fewer side effects. So this is going to be used for any of our inflammatory diseases like osteoarthritis, rheumatoid arthritis, some pain, some menstrual pain. But this is only going to bind to COX-2. So it doesn't bind to COX-1, which is our good receptor. It only blocks that COX-2 receptor, which causes our pain and our fevers. So this one is a better option for our patients who already have those GI issues and those bleeding issues, because it's not going to affect the COX-1 receptor. But basically just fewer adverse effects than our first gen, like our ibuprofen and our aspirin. And they're much better tolerated. Next, we're going to move on to some of our steroids. So prednisone is an oral corticosteroid, basically used to decrease some inflammatory response. So reduce redness, pain, swelling, loss of function possibly at an affected area, but it just is going to slow down all those inflammatory pathways and stop that production of those inflammatory receptors. So side effects of our steroids, a lot of it can be related to Cushing's syndrome, which you guys are going to go over in Complex Health 2, and I have a little picture here at the end. But basically, high levels of steroids decrease the action of the adrenal gland, and then puts that patient at risk for Cushing's if they're used long term. And then again, like our hypertensive medications, we want to taper our patients off of steroids, which I'm sure you guys are familiar with if you have taken steroids before. But you start off at this dose and you slowly go down until you're not taking any more. And then our steroids can also cause symptoms of immunosuppression. So we just want to educate our patients, wash our hands, avoid large crowds without a mask, get our vaccines, and stay away from any large group of germy kids. And then next is hydrocortisone. Same thing, steroid, but this is just used parentally, so it's injected. A lot of the times it's given in patients, if they have like knee pain, swelling, elbow pain, things like that. But this is just given, through a needle, an injection instead of orally. And then this is my little picture of Cushing's syndrome. So a lot of times with our transplant patients, they are going to be on corticosteroids long term to prevent the body from rejecting that organ transplant. So if you're ever on a transplant floor, you're going to notice some of your patients are going to have like that moon face specifically because they're on those high dose of steroids, and they're going to be on them very long term to prevent their body from rejecting the transplant. But that's just due to corticosteroids. And you guys will get more into Cushing's and adrenal gland things in Complex Health too. And next I have infliximab. I don't know if you guys went over this, but this is just a medication used for rheumatoid arthritis. It's a TNF blocker, and TNF is kind of like a receptor and enzyme, I guess, if you will, that's responsible for inflammation. This drug is used mainly to treat the autoimmune disorder rheumatoid arthritis, which is just pain and swelling in our joints. So basically an anti-inflammatory again, and it kind of just slows that disease progression, so it's not completely overtaking their body and causing severe debilitating pain. Next, we have one of our anti-gout medications. This one is used for gout prophylaxis. So this is used to stop a gout attack from occurring. So we know that gout, I think you guys go over this in your Complex Health 3 exam, but basically gout is just that overproduction of uric acid in the body. So this medication, allopurinol, is going to decrease the production of uric acid. Very few side effects, just gastric irritation, and then severe would be GI bleeding. But main thing with this is our patients should avoid alcohol, caffeine, and thiazide diuretics, because those are all going to increase the uric acid levels in the body, and this medication is trying to get rid of that. So if they're taking all those things, then we have to increase the dose, when that could just easily be eliminated by dietary changes. Okay, next, we're moving on to our non-opioid and opioid analgesics. So we have our acetaminophen. A lot of people sometimes think that this medication is an NSAID as well, but it's not. So acetaminophen kind of works on our prostaglandin, which is our fever enzyme. So it kind of blocks the fever at the hypothalamus, and then it just basically helps our body get rid of all that heat buildup from our fevers. Um, and then really important down here, we have the antidote because I'm going to go over into acetaminophen toxicity in a minute. But this is our antidote down here. I don't know if you can see it because it's kind of blocked on my screen. But some side effects are just headache, insomnia, GI distress, and rash. And then we know that acetaminophen is very, very toxic to our liver. So with our patients who have, cirrhosis of the liver, they're on drugs that affect the liver pretty severely, like tuberculosis drugs. Our liver transplant patients, our alcohol abuse patients. We're going to want to avoid giving them acetaminophen because it is very, very toxic to our liver. And I have a little slide with all the stages of acetaminophen toxicity. But always check your liver enzymes, your ALT and your AST before you're giving this medication. Keep that out of reach of children because it is very toxic to their little livers. Again, avoid that alcohol ingestion while you're taking acetaminophen, especially if you're taking high dose acetaminophen. And then does anybody know, this might be a weird question that you guys didn't go over, but what the maximum dose for adults is for acetaminophen? Yep, 4 grams a day. And then if it's taken more frequently, it's 2 grams a day. Good job. So this is just a little picture of acetaminophen toxicity. So stage 1, not too severe, just that nausea, vomiting, abdominal pain, those GI symptoms. Your LFTs may be normal still. And then stage 2 is when that actual liver injury is going to start developing. So they're going to start feeling it in their liver, in their right upper quadrant. You may see a rise in their ALT, AST, their bilirubin, and their INR. And then stage 3 is where that hepatotoxicity peaks. So this is where it becomes super dangerous and it can lead to death. So we always want to try and avoid it before we get to stage 3. And then if they make it past stage 3, that is recovery stage for those who made it past. But always monitor our liver enzymes in our patients, especially if they have a known history of liver disease if they're taking acetaminophen. Okay. Next is our morphine. I'm sure you guys are familiar with this. This is our opioid, our main opioid receptor. Um, and it's just mainly used for severe pain. So it's going to work as to suppress our pain impulses, but it's also can be used as an antitussive, which I think we went over in our last exam review, but it basically stops that cough reflex in our medulla in our brain. Some important side effects, constipation. So we know, especially in our elderly patients who are taking morphine, that this puts them at a higher risk for constipation because it slows our GI tract down. So we want to encourage fluids, fiber, and mobility if possible to help everything get moving. Again, mild sedation and then respiratory depression is a really important adverse effect to note with morphine. So for our patients who are on high dose morphine, especially IV push morphine, we're going to want to make sure that we're doing a really good respiratory assessment and a neuro assessment to make sure that they didn't overdose on their morphine. So again, don't give this to patients who have suffered a head injury because we want to make sure we're assessing our level of consciousness and doing our neuro checks. And it's going to be difficult with patients who already have, I guess, a history of head injury because you're not going to be able to fully assess, is this the head injury or is this the morphine? So just avoid it in our patients with a lessened level of consciousness. And then we're going to get into the Narcan, which is the antidote to morphine or opioids, in a few slides. But always make sure to monitor respiratory rate and things like that. But fluids, fiber, activity, if possible. I know a lot of people on morphine are immobile due to like fractures and things like that. So just increasing fluid and fibers for those patients. Next, we have fentanyl, which is another opioid used for severe pain. Pretty similar, just knowing that fentanyl is a lot more potent than morphine. So we want to be really, really cautious when we're giving fentanyl to our patients, especially those that weigh less than 110 pounds. So like our sweet little old ladies, we want to make sure that we're, assessing them really well, respiratory wise and neuro wise, because it's very easy to overdose on fentanyl. And fentanyl, you see a lot of times fentanyl drips in the ICU setting, but it's just more potent than morphine. Just know that you have to do more thorough assessments for fentanyl. And then these are just signs and symptoms of opioid withdrawal, especially to know if you carry Narcan around, that would be really important. But pretty much anxiety and diaphoresis are things that you see a lot on ATI. But yeah, this is just a cute little slide I like. So this is our Narcan. I'm sure, again, you're familiar with Narcan or naloxone. But this is an opioid antagonist. So this is our antidote for morphine overdose. It's going to reverse the symptoms of toxicity and overdose. It's basically going to go to those receptors where the opioid's trying to go to, and it's going to block them. So it displaces that opioid, and then that opioid is going to be excreted out of the body because those receptors are blocked by the Narcan. Some side effects because they're coming out of that overdose: sweating, flushing, agitation, difficulty breathing, hypo or hypertension, tachycardia, nausea, vomiting. And then if they did overdose because of, pain, they're going to have that pain feeling again. But always make sure this is in your patient's chart if they're on, PRN or scheduled morphine, because there have been times when I've been in clinical and patients have just gone, from fine to being very confused, and they've had such a decrease in level of consciousness, and we had to, figure out what that is, and we look and we see that they had morphine recently. So always make sure that your Narcan's available and ready for patients on morphine. And then for patients that are suspected as an opioid overdose, we can give this. And if it reverses it, we know that that was an opioid overdose. So it can kind of be used for that as well. Any questions on any of the pain medications? Okay, perfect. Next, we're going to get into some of our heavier cardiac drugs, like our cardiac glycosides, anti-anginals, and antidysrhythmics. So first, we have our digoxin, which I'm sure you guys remember from Complex Health 1, but this is our cardiac glycoside used for heart failure. So it's going to slow that heart rate, increase that contractility, and then decrease that rate of conduction. Main thing for this is knowing that what our side effects are and what our adverse effects and our signs of dig toxicity and our therapeutic range. So for side effects, we have that bradycardia, fatigue, nausea and vomiting, anorexia, and that headache. And then for our dig toxicity, a main side effect that you often see on test questions is green-yellow halos around the objects. So for our patients who are over that therapeutic range, and remember that therapeutic range is 0.8 to 2, if they have any reports of seeing green or yellow halos, nausea, vomiting, blurred vision, weakness, then we know that we have to check their dig levels. And always make sure that we assess the apical pulse before we administer digoxin, because we know it affects the heart rate. basically just monitoring our DIG level, really important. Again, like our beta blockers, hold if the heart rate is less than 60. But DIG toxicity is something that ATI loves to test on, and I know you guys talk about a lot in Complex Health 1. But the antidote over here, digibine or digoxin immune fab, that's just what you're going to give to reverse the toxicity of digoxin. Next, we have our nitroglycerin, or a lot of people just call it nitro. This is a nitrate and used often for angina or myocardial infarctions or heart attacks. So this is just going to basically open up those coronary arteries as wide as it can. It's a potent vasodilator. So it's going to basically lower that oxygen demand that the myocardium needs, especially in our patients who, are having a heart attack. We give them this, and we teach our patients who have a known history of angina or MIs. If you feel that chest pain, take a nitro, and I have it over here, the technique. So if they're having chest pain, they take one nitro, then they take another 5 minutes later while they're calling 911. Main side effect of nitro is a really severe, painful headache. So for our patients who take nitro for the first time, they're just going to report a really, really, really bad headache. And then another important thing to note with nitro is it is completely contraindicated with any erectile dysfunction medications like Viagra or sildenafil. So we always want to make sure before we give this, do we ask our patients, did you take any of these medications today? I want you to know because it is completely contraindicated and it can lead to very, very serious complications if you did. And I know Dr. Rosales probably went over it with you guys, but you always have to ask and make sure you get an honest answer from some of your patients because sometimes they won't admit, but I'm sure he went over that with you guys. Next is our isosorbidide. Same thing, another nitrate used for angina. Basically the same thing as our nitro, just used less. But it's just more short acting, so it's used basically for acute angina instead of our MIs or heart attacks. Next, we have our calcium channel blockers, ditalizam and verapamil. So there's two classes of calcium channel blockers. There's our non-dihydropyridines and our dihydropyridines. So these two, ditalizam and verapamil, are very nice drugs, are going to be non-dihydropyridines. So these are non-selective. So that means they impact the blood vessels and the heart. Basically, the function of them is just to lower that blood pressure and the workload of the heart and promote vasodilation of both the heart and the blood vessels. So these are non-selective. They're not just picking either the heart or the blood vessels. They work on both. So mainly these are going to be used for a lot of disorders. So like hypertension, heart failure. Sometimes they can be used as antidysrhythmics. So for patients who are stuck in certain arrhythmias, they can be used as well. But just knowing that these sorry, I had to sneeze. Knowing the side effects of these: constipation, nausea, headache, flushing, and then something that I see a lot is calcium channel blockers can cause edema in the legs. And I saw that the other day and I remembered it from this. But yep, just knowing that these, they are used for hypertension, so hypotension is a side effect. And then for our calcium channel blockers, always tell our patients to avoid grapefruit juice because that completely counteracts the action of the medication. Next, we have our dihydropyridines. So these are going to be our selective calcium channel blockers, our nifedipine and our amlodipine. So these all end in PINE. These are going to be selective, so they only impact the blood vessels. So these are mainly used for hypertension. But same thing, just knowing the difference between the two classes, non-dihydropyridines, non-selective dihydropyridines, selective. but pretty much the same thing. No grapefruit juice with these either. I know that they're a different kind of class, but again, no grapefruit juice. And then increase hypotensive effects with other antihypertensives because these only affect the blood vessels. Next is our amiodarone. So this is our potassium channel blocker. This one is an antidysrhythmic. So it's used to convert our AFib or A flutter to normal sinus rhythm because it's a potassium channel blocker. So it's going to affect those electrolytes in our heart. Used for arrhythmia or dysrhythmias. Many side effects for these medications. As you can see, you guys don't have to remember every single one of these, but something that sticks out and is different is sometimes patients may have like a blue-gray discoloration of their face, but that'll go away in about a year. But that's just something that kind of sticks out, and when you see it, you know, oh, that's amiodarone. Any questions on those? Okay, next we have our diuretics. These are my favorite cardiac medications. Um, Basically, diuretics just make you pee. A lot of patients call them their pee pills, but they just help our patients with excretion, whether it be fluids, electrolytes, or from a certain disease process. Mainly, diuretics are going to be used in our patients with heart failure because we know in heart failure they're retaining lots of fluids, and we want to get rid of all those fluids. So we're going to use diuretics. So first we have our thiazide diuretic or hydrochlorothiazide, used for moderate to mild hypertension, edema, which is going to be related to our heart failure, ascites, which is related to cirrhosis or liver failure, and then nephrotic syndrome, which is just too much protein kind of going through our kidneys, and then renal caliculi, which are kidney stones. But this is gonna block that sodium reabsorption on the renodistal tubule. The actions are kind of all similar, so you guys don't really need to dive too deep into that. Just know that some are more preferred over others, especially in patients with certain disease processes, which we're going to go over. But they all, because we're excreting so many fluid and electrolytes, they're all going to have a side effect of fluid and electrolyte imbalances. So we know our sodium, our potassium, those are all getting excreted, and then our water additionally. So for our hydrochlorothiazide, we want to make sure that we're monitoring our blood pressure, our electrolytes, and any signs and symptoms of hypokalemia because this is not a potassium sparing diuretic. So it's going to kind of spit out that potassium along with all that water. And then for all of our diuretics, we want to kind of encourage our patients to take that in the morning because we don't want them waking up all night and going to the bathroom, especially if they're elderly and confused. Having them wake up, you know, every hour when they're sleeping in the dark, walking through their house or wherever they may be, puts them at a higher risk for injury, especially related to falls. So our furosemide or Lasix is probably one of the most common diuretics that we see in the clinical setting. This is going to be our loop diuretic. Is especially helpful in our patients with pulmonary edema, which is related to their heart failure, the right-sided heart failure. So furosemide or Lasix is going to help get all that fluid off of our lungs by blocking that sodium and chloride in the loop of Henle. But again, fluid and electrolyte imbalances with all diuretics are side effects because it's just getting all lost in the urine. And then elevated BUN and creatinine. So furosemide and Lasix or furosemide Lasix is pretty hard on our kidneys. So for our patients with chronic kidney disease, it may not be preferred over another diuretic if possible. And then for nursing care, a really important intervention that we want to do. So when we're giving furosemide IV push, we're always going to want to administer it very slowly because it can cause hearing loss or tinnitus if it is injected too rapidly into the IV. And then again, because this isn't a potassium sparing diuretic, We want to monitor our potassium levels, especially for a patient who is taking digoxin, because I don't know if I mentioned that, but digoxin, potassium potentiates digoxin toxicity. And then these are just some signs and symptoms of hypokalemia to watch out for in our patients that are taking high doses of diuretics. So muscle cramps, weakness, fatigue, paralysis, constipation, and then some severe ones, respiratory failure, and especially irregular heartbeat or heart rhythm would be more. So this is our potassium sparing diuretic, our spironolactone. And this is going to be used for edema, again, associated with heart failure, cirrhosis, and basically it is just diuresing without affecting our potassium in the body. So they're going to excrete all that water, but their potassium is going to hang on. So we're still going to want to monitor our potassium levels, but we're not watching for symptoms of hypokalemia. We're going to want to watch for hyperkalemia. So in our other two diuretics, we might encourage our patients to increase their intake of foods containing potassium because they're spitting out all that potassium. For our patients on spironolactone, we're going to want to do the opposite. So don't increase any foods or supplements that contain potassium because they're holding on to all that potassium. And then salt substitutes as well. Okay, any questions on the diuretics? Okay, so moving on to some of our antihypertensives. So first we have our alpha-adrenergic antagonists, our prazosin or mini-pres, used for hypertension. Basically, it's just going to relax those blood vessels by blocking those receptors in the arteries and in those smooth muscles. And additionally, it's going to block the effects of norepinephrine. So basically, everything for this medication, especially side effect wise, pretty similar to our beta blockers. Just different mechanisms, I guess, that it works in the body. But an important thing to note for prazosin is if this is the patient's first dose, they may have first dose hypotension. So we're going to want to stay with them, monitor their blood pressure, educate them not to, run out of bed really quickly because they could have some pretty severe hypotension and some symptoms associated with that. And then much like our nitrates, we don't want to give this medication with any ED medications because it may result in profound hypotension, which can lead to circulatory collapse. Okay, next is our hydrolyzine. This is a direct acting arterial vasodilator. This again used for hypertension, so it's going to lower that blood pressure and decrease the workload of our heart. It acts directly on our peripheral arteries and basically just opens them wide up, which lowers our blood pressure. Some side effects associated with this, tachycardia and nasal congestion are going to be probably the most common ones, I guess. But we know that we're opening all those blood vessels up. So nasal congestion is really common because everything's open and wide. And that's kind of how nasal congestion works is when we have severe vasodilation in the sinuses. And then an adverse effect is going to be sustained tachycardia. So if the patient all of a sudden jumps and has like an increase in their pulse from like 100 to 120, we're going to want to report that to our provider as soon as possible. Next, we have our ACE inhibitors, which are really, really common medications used to control hypertension. So these are all going to end in pril, P-R-I-L. So captopril, enalapril, and then quinapril. So these are, again, used for hypertension. So they're going to vasodilate our blood vessels. They're going to block that angiotensin 2 and then block the release of aldosterone. So a really common side effect with our ACE inhibitors that is going to be seen a lot on ATI and NCLEX practice questions is persistent dry cough. So dry cough may indicate that the patient needs to be switched to an ARB, an angiotensin blocker, which we're going to go over on the next slide. But normally those are better tolerated than ACE inhibitors, especially for those that have had a history of not responding well to ACE inhibitors. But a rare side effect after that many patients have after they experience, the dry cough that notifies the provider that they're having an adverse experience to this medication and may need to switch to an ARB is angioedema, which is basically just severe swelling of the face. So they swell up around their eyes and their lips, and that's associated with an adverse effect to ACE inhibitors. And that may indicate that they need to switch to an ARB. And these are ARBs, are losartan and are valsartan. They all end in sartan. So these are our angiotensin 2 receptor blockers, or ARBs. Same intended responses as our ACE inhibitors. They're just better tolerated in many patients, especially those who have had those side effects of the, persistent dry cough and the angioedema. But these are just more well tolerated, I guess, than our ACEs back here. Okay, next we're moving on to our anticoagulants, antiplatelets, and thrombolytics. Does anybody have any questions? Okay, perfect. So here are some lab values. I know they're kind of doing away with memorizing lab values, but just some good things to know. So our patients who are taking warfarin, we're going to want to monitor their INR. For our patients who are taking, who are on heparin, we're going to want to monitor their APTT. And then for all of our patients on all anticoagulants, blood thinners, whatever you want to call them, we want to monitor their platelet levels. Can anybody put in the chat the normal level for platelets? Yep, 150 to 400,000. So those are our normal platelet levels. So first I want to start off with our heparin. This is going to inhibit the thrombin in our body, which we know works in our clotting cascade. But mainly our heparin is used to prevent and to treat DVT, which is deep vein thrombosis, and our pulmonary embolisms. And then for our patients who have a known history of AFib, we know that AFib puts the patient at an increased risk for throwing a clot. So many of our patients who come in, with first time AFib, we're going to start them on a heparin drip to prevent them from throwing a clot and possibly having a stroke. And then it's also used in our cardiac surgeries to help thin out the blood, especially in our cardiac catheterizations. They're also going to be on a heparin drip. But just knowing that for our heparin, we want to monitor our APTT levels, do them as they're ordered, and make sure we're on top of that and making sure that the patient's heparin remains therapeutic, because if it falls out of that therapeutic range, they could be at risk for throwing a clot because their blood is not thin enough, or they could be at risk for hemorrhaging because their blood is too thin. So another important thing to monitor is our hemoglobin and hematocrit. So we know for hemoglobin and hematocrit take a drastic dive, that could indicate that our patient is having some internal bleeding, possibly a GI bleed or any other internal hemorrhaging. Same thing with blood pressure. Blood pressure drop could indicate hemorrhaging, and then tachycardia is another very early sign of hemorrhaging. And then knowing that our antidote for heparin is protamine sulfate, and that's going to be important to remember because ATI loves to test you guys on protamine sulfate. But just knowing the antidote to all of our anticoagulants is very important. Next is our enoxaparin, or Lovenox. This one very, very common in clinical but it's used for DVT prophylaxis. So in our patients, especially our bedbound patients who, aren't very mobile, we're going to give this to them to prevent the DVT, the deep vein thrombosis, because they're immobile, they can't get up and move around. And when you're, confined to bed, it puts you at a higher risk for DVTs and pulmonary embolisms. So this is just a form of heparin, a low molecular weight heparin. But it's just a safer version of heparin, and it is given subcutaneously in the abdomen. So for this, we don't need to monitor the patient's PPT, because this is, again, less dangerous, I guess, if you would, than our heparin. It has less side effects. So we are giving this subcutaneously in the abdominal area. A really important thing to remember is they come pre-filled syringes, at least at my clinical location, but we do not want to expel that air bubble. I know it seems really tempting because you always want to get the air out, but the air bubble needs to stay at the top. And then we give it subcutaneously, and we don't rub or, aspirate that skin afterward. But enoxaparin is generally a less dangerous version of heparin, and it's used more often. Next, we have our warfarin, very, very common medication. A lot of people are on this medication, especially those who have persistent AFib. So this is going to prevent those clots that we talked about in our patients who have persistent AFib. We know that they're at risk for throwing clots. So they're going to be on warfarin to prevent them from a stroke or a pulmonary embolism. But basically, warfarin works with vitamin K. So we know vitamin K kind of increases our clotting ability. So it's going to kind of stop that vitamin K production and thin out our blood. A lot of people refer to this one as like the blood thinner. When you talk to patients, they're like, oh, my blood thinner, this is what they're talking about. But side effect wise, adverse effect wise, bleeding, hemorrhage, everything like that. Antidote to this, because it is stopping the vitamin K production in our body. We know that if we give vitamin K, that's going to be our antidote. So for our patients who are taking this, we want to avoid foods high in vitamin K. Does anybody have any examples of foods that are going to be very high in vitamin K? Yep. Avocados, green veggies, basically our dark green leafy vegetables are very, very high in vitamin K. So we want to tell our patients not to take that because that's going to interfere with their therapeutic warfarin levels. And then to assess, to make sure that our patient's warfarin is therapeutic, their INR needs to be measured. So we know that heparin, APPT, and then warfarin, INR. So our INR levels, does anybody know what those should be in between for our warfarin patients? Yep, 2 to 3. Perfect. So our warfarin is our long-term medication. We can't really send patients home on heparin drips. So we try to get them converted to warfarin to go home to control their risk for clotting. Next is our apixaban or Eliquis. Again, this is kind of used for prevention of blood clots. Basically just same thing. Some individuals use it for AFib or DVT. A lot of patients who are going home with new stents are prescribed this medication, but again, a blood thinner, if you will. Side effects, adverse effects, bleeding, blood in urine, stool. A blood in the stool would be any dark stools. So remind our patients that they're having any really dark stools that they haven't had before, that could indicate that they're having some GI bleeding. But just assess platelets, blood pressure, heart rate, any signs of hemorrhaging. But Pretty much all of our anticoagulants, blood thinners have the same side effects of bleeding. Our clopidogrel or Plavix, again, is a platelet used for it's the action of platelet aggregation, so it prevents those platelets from sticking together and kind of clogging up our arteries. So for our patients, again, like the Eliquis, this is going to be used for those patients who go home with a new stent to keep that blood thin and flowing through their stents after they had just had an MI. So the platelets are going to be less sticky, so they're not going to stick together and make a clot. So our Adaplase, our TPA, this is a thrombolytic agent. So this is used for patients who have an ischemic stroke. So the blood supply is completely cut off to an area of the brain, and the Adaplase is gonna it's called our clot buster. So it's basically just gonna break up that clot, and completely thin out all of our blood. So for this medication, we really, really, really want to watch our patients closely. There's a lot of steps to giving Adaplase, and it's very facility specific. They have their own policies written up about it. So I'd encourage you to go look at your facility's policy concerning Adaplase or TPA. But basically, any bleeding, oozing from their gums, their wounds, cuts, those are side effects because this is just completely going to thin out our body's blood. So I just want to monitor our patients very carefully. Okay, next we're moving on to our anti-lipidemics. So I don't know where my little there it is. So these are statins. These are used to lower that bad cholesterol in our body. So we know that HDL is good cholesterol and LDL is our bad cholesterol, along with triglycerides. So our patients with high triglycerides or hyperlipidemia, this medication is going to be used, and it's a very common medication. Most of the side effects related to statins are abdominal or GI related, so constipation, abdominal cramps, things like that. And then a very severe adverse effect is rhabdomyolysis, which is just going to be that breakdown of skeletal muscle, and it's very dangerous and very severe. And we can inform our patient that they may be experiencing this if they're having severe muscle cramps and if their urine starts to look like Coca-Cola. So in our patients who have rhabdo, if they start experiencing, darker urine than normal, we want to tell them to come in and get that checked out because that could indicate that their skeletal muscle is pretty much breaking down and being excreted through the kidneys and the urine. But for our teaching and our nursing care, we want to educate our patients that, this isn't an overnight treatment. So it's going to take weeks, possibly months for their triglycerides or their LDL to decrease. And we want to teach our patients to take this at bedtime and then report again any unexplained muscle pain, weakness, tenderness. Next is our ezetimibe or Zetia. This is basically just used when that low fat, low cholesterol diet is not working for a patient, especially those that are allergic to statins, because I've seen statins as a pretty common allergy recently, but this is just used for patients who can't, follow that low fat diet, that low cholesterol diet. It's just not working for their body, and they're still having that increase in triglycerides and LDL. So this is just going to stop that absorption of cholesterol from that small intestine, which is again going to decrease the levels of LDL and total cholesterol in our body. Most of these medications, GI related side effects, so stomach pain and diarrhea. And then it can have the adverse effect of angioedema, much like our ACE inhibitors. Again, monitoring for any skeletal muscle disorders, liver disease, monitor that liver function test, ALT and AST, and then take that medication once daily at the same time. Another one of our anti-cholesterol medications is our cleostatazole. Um, oh, sorry, this is not anti-cholesterol. This is going to be used for our PAD, our peripheral arterial disease. So in our patients, can anybody kind of explain intermittent claudication in our PAD patients? You can just do like a little blurb in the chat. Yep, perfect. So intermittent claudication is related to peripheral arterial disease, and that's basically when we get leg pain or cramping or really uncontrollable pain when the patient is moving or exercising because there is no blood flow to those peripherals. So everything's cut off. So this is going to kind of help vasodilate in those patients where it is not too severe. And then I noticed I just had the action messed up. Oh no, I didn't. Okay, never mind. But it is used in our patients who are having those symptoms of intermittent claudication, and it's going to help vasodilate those arteries and help get more blood flowing to our peripheral limbs, especially our legs, because we know that's kind of where most of our intermittent claudication symptoms occur, especially in those that are exercising. Um, but that's basically it with this medication. Nothing crazy. Alright, next I have a few practice questions. Does anybody have any questions or need me to go back to anything? Okay, perfect. A newly admitted client takes digoxin 0.25 milligrams a day. The nurse knows that which is a serum therapeutic range for digoxin. Yep, so the correct answer is B, 0.8 to 2.0. When a client first takes a nitrate, the nurse expects which symptom that often occurs. Yep, headache. So a very severe headache is associated with taking nitroglycerin. And then to help alleviate this patient's headache, we can give them Tylenol. The healthcare provider is planning to discontinue your client's metoprolol. What instructions should the nurse give the client regarding the beta blocker? Yep, so the answer is going to be D. The beta blocker should not be abruptly stopped and the dose should always be tapered down. So we always taper our beta blockers to avoid rebound hypertension, tachycardia, arrhythmia, and angina. The nurse reviews the client's lab values and finds a digoxin level of 10, a heart rate of 72, and a serum potassium level of 5.9. What is the nurse's primary intervention? The correct answer is going to be C. So the nurse is going to administer digoxin immune fat, which is the antidote for digoxin toxicity. The reason the nurse would give this is because the dig level is way past 2 and the potassium is increased, which I mentioned potentiates our dig toxicity. A client is taking hydrochlorothiazide 50 milligrams a day and digoxin 0.25 milligrams a day. What type of electrolyte imbalance does the nurse expect to occur? Yep, great job. So the answer is A, hypokalemia. Because hydrochlorothiazide promotes excretion of water and potassium. Um, so we know that the nurse is expecting signs and symptoms of hypokalemia. What would what medication would the nurse expect signs of hyperkalemia? What diuretic, I should say. Yep, spironolactone, which is our potassium-sparing diuretic. A client with acute pulmonary edema receives furosemide or Lasix. What assessment finding indicates that the intervention is working? So the correct answer is going to be C. So we know pulmonary edema is too much fluid in our patient's lungs. I can see how you want to pick D, urine output of 30, but that's not directly related to the disease process because we want that patient's lungs to be clear and not have any crackles or adventitious sounds. A nurse is caring for a client who is taking an angiotensin converting enzyme inhibitor or an ACE inhibitor and develops a dry, non productive cough. What is the nurse's priority action? So, our correct answer is going to be A. So we know that that if they develop a dry, non-productive cough, we're going to want to call the healthcare provider and switch the medication because that may indicate that they need to be switched to an R. But I can also see how B would be an answer as well because assess first and figure out maybe if they have any symptoms of an upper respiratory infection. So honestly, I would have picked B as well. But yeah, I don't like that question. For the patient receiving periodic morphine via IV push, which of the following findings would be of utmost concern to the nurse? Yep, correct answer is C. So we're going to use our ABCs, airway, breathing, circulation. So we know that morphine, especially given IV push, puts that patient at risk for decreased respirations. So that's going to be the most concerning. And what would we administer to reverse this? And we're going to give Narcan or naloxone. Your patient is taking atorvastatin and develops yellowing of the skin, abdominal pain in the right upper quadrant, and nausea. What lab results below correlates with the finding? Yep, so our correct answer is going to be A. So yellowing of the skin is jaundice, abdominal pain in the right upper quadrant is where our liver is, and then nausea. So these are indicating that the patient may be having some liver impairment, which is going to be shown by an elevated ALT and AST, or liver function test. A nurse is planning to administer subcutaneous enoxaparin 40 milligrams using a pre-filled syringe of enoxaparin 40 milligrams per zero point 0.4 ml to an adult client following a hip arthroplasty. Which of the following actions should the nurse plan to take? Yep, our correct answer is B. So let's go through each one. So expel the air bubble from the pre-filled syringe before injecting. No, we should never expel our air bubble from our enoxaparin syringes. B, insert the needle completely into the client's abdominal tissue. So yes, this is correct because this is subcutaneous and it is given in the abdominal area. So we want to make sure we're putting that needle completely into their subcutaneous tissue in their abdomen. And then C is incorrect because we know we only get this in our abdominal area. And then D, aspirate carefully after inserting the needle into the client's skin. So no, we never aspirate, especially not with enoxaparin. Okay, so next I made this little case study um, about diuretics, but James, a 58-year-old patient, has been recently diagnosed with hypertension. His resting blood pressure is 158 over 92. He's prescribed hydrochlorothiazide 50 milligrams a day and is told to eat food rich in potassium. Our first question is going to be, how does hydrochlorothiazide differ from spironolactone, and what other similarities and differences? And you guys can just put like little blurbs. You don't need to go crazy typing everything out. Okay, we'll go through this. So hydrochlorothiazide is a thiazide-like diuretic, and it excretes water and potassium. Spironolactone is a potassium-sparing diuretic, and it excretes water but holds on to the potassium. Both can be used for heart failure, and then both can cause food and electrolyte imbalances. Also, we should encourage our patients on either drug to take it in the morning to avoid nocturia, which is waking up in the middle of the night to go to the bathroom. Next question is, why is it necessary for James to eat foods rich in potassium when taking hydrochlorothiazide? So we know that it excretes potassium. So to maintain his levels of potassium, he should eat foods high in potassium so he's not at risk for hypokalemia. Does anyone have any examples of foods that are rich in potassium? So we have bananas, avocados, yogurt. A lot of beans are high in potassium. So what are some nursing interventions that should be considered when taking hydrochlorothiazide? We want to monitor our vitals and our electrolyte levels. We want to watch for any signs and symptoms of hypokalemia. Monitor our patients' daily weights and I's and O's, especially if they're chronic heart failure patients. Again, suggest that the patient takes this medication early in the morning, and then instruct our patients to change their position slowly, especially if they're coming from lying down to standing. So when getting out of bed in the morning. And then, if necessary, we may need cardiac monitoring to watch for any dysrhythmias related to hypokalemia. And then again, have that patient eat foods high in potassium. Okay. Any questions? Or does anybody need me to go back to anything?